So we are live in 5, 4, 3, 2, 1. We are live now.
So very good evening to all of you again for this 24th episode of Young Surgeon Forum YSF. Now this has been in association with Maharashtra Orthopaedic Association, the brainchild of Dr. Wasudeo Gadegone, to give the academic platform for young budding orthopedic surgeons to showcase their work on this global platform along with the OrthoTV. So on this 24th episode, we are very fortunate to have Navi Mumbai Orthopaedic Association as a guest society for this today's episode. We are having mixed bag kind of cases from all the subspecialties in orthopedics, 5 cases from the trauma, the pelvis region, spine, orthoplasty, as well as arthroscopy. For the convener for today with me is Dr. Sanjay Dhar sir, who will be the moderating this today's session. We do have this NMOA President and Secretary also with us. So now may I ask Dr. Wasudeo Gadegone sir to give a brief introductory welcome for this today's session.
Welcome all viewers of Maharashtra Orthopaedic Association and viewers of OrthoTV. Now this is a webinar of Maharashtra Orthopaedic Association Young Surgeon Forum. Today this will be conducted by Navi Mumbai Orthopaedic Association. Young surgeons will deliver their work and also will discuss amongst ourselves what are the things best possible can be done for the patient. Dr. Sanjay Dhar from Mumbai, and he is a president-elect of Bombay Orthopedic Society, is a kind enough to arrange this program of Young Surgeon Forum case-based discussion on OrthoTV. I thank Dr. Sanjay Dhar as well as the President and Secretary and all members of those who are taking part in webinar for their contribution for the betterment of educational activity of the Maharashtra Orthopaedic Association. Thank everybody, and I now hand over the proceedings to Dr. Sanjay Dhar. Over to Sanjay Dhar.
Thank you, Gadegone sir. It's my honor and pleasure to host this meeting on behalf of Navi Mumbai Orthopedic Association. With your guidance, you are always on the forefront of academic endeavors, Maharashtra and probably whole of country. I take it up as a pride to organize this. So I have sort of arranged very young surgeons who are all resident and work in different hospitals of Navi Mumbai. Dr. Ajit Chalak, Dr. Gaurav Kanade, Dr. Rohan, Dr. Nilesh Vishwakarma, and Dr. Abhay Chalani. They are all young surgeons practicing their subspecialties in various hospitals. Before we start, this is a case-based discussion where we will have small case presentations, and then we will have their own viewpoint around how to manage such cases, and we can all give our own inputs to the faculty. And before we actually start the real academic proceedings, I would request Dr. Ashok Godke, who is the Secretary of Navi Mumbai Orthopedic Association, to introduce the organization to the rest of you in a very brief time. Dr. Godke.
Good evening. Good evening. Respected President Dr. Gadegone, BOS President-elect Dr. Dhar, Dr. Manoj Pahukar, who is always at front run to carry on all such academic activities. So our NMOA organization was formed 10 years back, and for last 2 years we have really geared up, and we are forming a good association. So in 2016 at Aurangabad MOA Con, we got ratified as a state, as a district, in a district part of MOA, and we are 10th and 11th September, which is the theme is Office Orthopedics, and it will be conducted at DY Patil. And I welcome all the speakers, and I'm really thankful to Dr. Gadegone sir, who always encourages all the young surgeons, because this is the platform where they can present their work and flourish. So thank you very much, Dr. Gadegone sir, Dr. Manoj sir, and I hand over the further proceedings to Dr. Sanjay Dhar sir. Thank you very much.
Thank you, Dr. Ashok. And with the permission of Gadegone sir and Dr. Manoj, I will start the proceedings. I think first speaker is Dr. Ajit Chalak. Dr. Ajit, are you ready?
Yes, sir, I'm ready.
So Dr. Ajit is a lecturer in DY Patil Medical College. He is a very prolific limb reconstruction who does a lot of limb reconstructions and iliceral surgeries. He will be presenting his first case. Dr. Ajit.
Yes.
So
good evening, sir. Good evening, all the faculty, and thanks for allowing me to present my work in the Young Surgeon Forum case-based discussion series. So I'll be presenting a case of revising the tibial iliceral with LRS fixator. So this is a 30-year-old female. She sustained a road traffic accident and had an open grade 3B fracture of the right-sided tibia, which was managed primarily with the iliceral fixator, and some sort of rotational flap was done. I don't have any previous X-rays. So she presented to us with this clinical picture where there is a frank purulent pouring pus coming out from the wound. We can see a exposed small screw over there. Not very hygienically maintained fixator. And this is the X-ray with which she presented to us. So there is a comminuted fracture. The initial surgeon has already tried to dock it, and the screw which is exposed can be seen over here, which was probably put to lag the big butterfly fragment. So what can be planned for this scenario? Should I go ahead, sir?
No, we can ask faculty, Dr. Gadegone, or even the other young surgeons. They can also contribute.
Okay, so I'll open this case for discussion, sir.
Yeah. Questions regarding this? You want any other investigation or any other details about this case? Can we have?
Manoj.
Do we have close up the?
This is since how many days from the initial index trauma?
Sir, around 3 to 4 months.
Okay.
The flap was done. What is the flap?
Sir, it was some rotational flap. The other leg was not involved. I mean, they have not anything harvested from the other leg. So this is a rotational flap, maybe a transposition or fasciocutaneous flap. The details are not available, sir.
So at present, what is the problem? There is a bone which is exposed. There is non-union. There is even the wires are infected, or what?
Yeah, the wires looks infected. There is frank pus which is pouring out from the wound. You can see in this picture, sir.
Yeah. I think they are able to make overall the fixator assembly well with a good apposition of means the axial and the rotational. All those alignments looks all right. It seems to be a soft tissue problem with local infection and infection which is not subsiding at the fracture site.
Yes, sir, probably. There could be some loose pieces of the bone which don't have any attachment with the muscles. So that could be the source of the infection, sir.
Yeah, but with iliceral is one of the standard method where for an infective non-linear or such kind of fracture, this is usually used. Now here, what we can see at the end of 3 months with such a good iliceral fixator assembly, still the infection is persistent. So what could be the problems over here like?
Yeah,
there is still an infection at the end of 3 or 4 months.
Yes, sir. And there is, there is severe, a lot of infection over there. The one reason which I could make out is probably the bone fragments which don't have any soft tissue attachments.
Yeah,
That would be the most important reason which I could see.
That is a very important point, because if you have done a good fixation, stabilization, but you have not removed the avascular diaphyseal fragments,
Yes,
I
sir.
think that will be trouble. So I think that youngsters, that is a very important point here, that it is not only important to align them well and to hold them well, but if you have not given vascularity and if you have what we call as bury the dead, you cannot expect union. So I think that is an important point. Dr. Gadegone, you want to comment on?
No, that is the only thing which we said. I endorse your view, because unless you remove the necrotic and dead bone, the things are not going to improve.
Yeah. Yeah, because as a surgeon, many times we are worried that whether we should remove these large cortical fragments and create such a huge gap primarily. But I think that is very important. It's very
Yes, sir.
important to these fragments unless they are attached with soft tissues. There's no point keeping them there and hoping for the best. You can go ahead, Ajit, now. The next.
Yeah. Yes, sir. So what was done for the patient was it was debrided. The loose pieces of the bones were removed, and we docked acute healthy bone ends together. We did around 6 centimeter of acute docking on table. So that helped us to get closure of the wound without any plastic surgery intervention. And we applied LRS in this case. We expected some soft tissue, some necrosis of the skin margins. So if at all any plastic surgery intervention is needed, it can be done with the LRS fixator, but not with the Ilizarov. So we went ahead. These are a few videos of debridement where you can see there are loose pieces of bone which are easily coming out. There is an infected necrotic granulation tissue which is there in the intramedullary cavity, which you can see it is being taken out. The necrotic tissues which was there intramedullary. You can see some loose pieces of bone as well, which don't have any soft tissue attachments.
Yeah.
They are just being embedded over there. So this is what we have done. We applied LRS. We tried to close the wound, but we had some doubt whether the skin is, because the closure was a bit tight, we had some doubt whether it may gape and we may need a plastic surgery intervention in terms of a cross leg flap or any free flap later. So we went ahead with LRS fixator. And this is what we have done. We have telescoped one end into the another. And we have docked the tibia by about 5 to 6 centimeters. You can see overriding of the fibula over there. But the safe limit of for acute docking its tibia is about 3 to 4 centimeters. But we have kept, we were watchful throughout the surgery. Both the vessels, dorsalis pedis as well as the posterior tibial artery, was very well palpable even after docking. So we kept the docking as it is and jammed the fixator.
Ajit, that is if you can stop for a brief moment. That is my question here for the people who want to know more. Between acute docking and bone transport, is there any way to decide where you should do this and where you should do that? And what is the safe limit? I think you said 6 centimeters, but what is the safe limit of acute docking?
Sir, the safe limit for acute docking in tibia is about 3 to 4 centimeters. In femur is about 4 to 5 or till 6 centimeters. In this case, sir, I was planning to get the skin closure primarily. So I have docked it as much as I can. And with that scenario, we were able to close the wound, and we were watchful throughout the procedure whether both the vessels were very well palpable. So both the vessels were very well palpable. The another question of you, whether to do a bone transport or
that as a parameter also, that your vascular pulse is felt while you are docking it.
Yeah, that is very important thing, sir, to dock acutely. Even in older patients with atherosclerotic vessel, the 3 centimeters of the docking, even that causes compromise in the distal circulation. So we need to be watchful. I mean, this centimeter the criteria is not that helpful. If the patient is, I mean, the height of the patient is long, we can dock furthermore. If the patient is anyway short, we should not dock till the upper limits, like 4 or 5 centimeters. So we have to be watchful for the distal pulses. And the another question of you, whether to do acute docking or bone transport. So I would prefer acute docking for the gaps which are less than 4 or 5 centimeters, because once we dock it, the fracture starts healing on the second day. On that time, it starts healing. So
Because
the problem of the bone transport, like skin invagination or bone grafting at later date, they usually do not occur with the acute docking, sir.
Okay.
Yeah.
And
So can I ask something?
Yes.
So you had done 6 centimeters of docking,
Yes.
and are you planning to do some limb lengthening or bone transport later
Yeah.
on?
I'm coming
Number
to
one.
that. My case is,
Number two. Why can't you continue Elizarov? Because as it is, the wound was closed and there was no question of any plastic surgery coming in. So these two, I mean, by an LRS, does it have some added advantage over Elizarov?
yeah. So the thing is, I will answer your second question first. If you look at how the wound has closed, you can see the closure is bit tight, isn't it? So if at all, if the skin gets necrosed and if the bone gets exposed again, then with Elizarov, no plastic surgeon in this world is comfortable enough to do any kind of flap with the Elizarov fixator on. So the plan was to put LRS fixator, because even if a cross leg flap can be done very comfortably with LRS fixator on. And if you look at the previous Elizarov fixator well, you can see the wires are not pretty well tensioned. You can see there is arcing of the wires over there. The rods are not parallel. There is some bending in the rods. That indicates that the frame is under stress. So that was the reason I have planned to do the LRS.
okay, go ahead.
Yeah, see, I just wanted to ask, what is the role of VAC? Because here the wound is there. Why do you want to primarily close it? It could have been slight gap and then putting some VAC and then allowing some granulation tissue or the pus to get out. Because in the first sitting, if you are try to do everything, it may not succeed. I think better to give serial debridements for such kind of wounds is another way to go ahead.
Yeah, VAC can be tried, yes, sir. But we have not done in this scenario, because these patients have some financial constraints, and a single sitting of VAC cost about 5,000 to 6,000. So there are some financial constraints for this patient, as I remember, sir.
Okay. Saoji sir, you are not audible. You wanted to ask some? Saoji sir, you are not audible, I think. There is some audio problem. You can write down the question, sir. I will ask him later. Yeah, Ajit, you can proceed.
Yeah. So this is the wound on day 10, and it started healing pretty well. And around 2 months, her all wounds were healed. There was no discharging sinus, and these are the X-rays at 2 months. You can see there is some minimal healing at the fracture site over there. So you can see the leg length discrepancy over there. So at this stage, we did a percutaneous osteotomy. We have added a middle clamp in the proximal fragment. The distal pins and the proximal most pins were kept as it is. We have dismantled the rail and added a 400 millimeter rail. And this is after the distraction has started. And this is at the end of the distraction. So we have equalized the leg lengths over here. You can see in the clinical pictures. So this is the left-sided picture shows the discrepancy, and the right-sided picture shows the equalization of the leg lengths. You can see the two clamps are touching each other in the left-side picture, and they are quite separated in the right side. So this is how we achieved her distraction. This is her gait during that period. So she is walking with the help of walker with the weight bearing as tolerated.
Ajit, just a question again. Why would you prefer to do it delayed, the distraction osteogenesis? Why not on the same sitting? Is it because it could have caused more vascular damage, or you wanted first the tissues to heal or something like
Yeah,
that?
I wanted my tissues to heal first, because if we do osteotomy in the same sitting, and if at all any plastic surgery intervention or anything needs to be done for the patient, then we will be dealing with the two fractures. One is the non-union and one is the osteotomy, which we do to get the length. So I always stage the procedures when it becomes too complex. That becomes easier for me and as well as for the patient to manage that.
And one more question, means the intervening, the transporting fragment, what is the optimum length you should have? How much away you should do the osteotomy, corticotomy or osteotomy?
Yes, sir. Sir, the ideal scenario to do the osteotomy is to keep at least 2 to 3 finger breadth gap between the pin and the osteotomy. But in this case, the fragment was very small, and so I have to go ahead with this type of situation, sir. Ideally, this is not indicated, but the situation was not permitting me to do anything else. So I went ahead and I did a sharp osteotomy.
Diaphyseal corticotomy, osteotomy, so
Yeah, this is,
normally.
sir, with LRS, it always comes as a diaphyseal only, because to get adequate stability in one fragment, we need to have the pins in the configuration of first 3 and 5th seats of the LRS. If we are putting the pins in first, third, and 5th seats of the LRS clamp, then only we get adequate stability in the adequate hold in the bone fragment, and the pins has to be a 6 millimeter tapered pins, sir, to get adequate hold on the bone fragment.
You want to wind up this case? Or
Yeah,
this is
so
over?
I'll just finish. So this is her gait after the well healing. She's walking unaided. See the clean pin tracks over here, and as I was telling, the seats of pin are first 3 and 5 of out of the in this LRS clamp. So in this middle clamp, this is a transport fragment. So we can put two pins are enough. I have put one pin in the first seat and the second pin in the fourth seat. So this is her gait after the fixator removal. She's having independent bipedal gait. So the take-home message is the most important factor in the management of the infected non-unions is debridement. It should be thorough. The removal of the devitalized bone fragments is very important. The bone gaps are manageable. Adequate resection of the devitalized bone fragments is necessary. The principles of LRS fixator should be correctly followed. The advantages of telescoping is it helps in correcting the alignment. It imparts the intrinsic stability to the fracture site, which helps the fracture to heal well. The application of the fixator becomes easy. It is a bit troublesome to maintain the alignment and apply the fixator in cases where we do a sharp transverse ends of the bone. The telescoping reduces the stress on the fixator. As the stress will reduce, there will be a lower incidence of the pin tract infection. Thank you, sir.
Okay. Thank you, Ajit. Thank you for.
It's a perfect restoration of the limb and a wonderful job you have done it. And it's a time-tested case that one must understand. The take-home message is whatever the necrotic tissue, it must be removed. Reconstruction and lengthening can be done very well if the soft tissues are covered. and neurovascular bundle is intact. So very wonderful case. Congratulations. And Sanjay Dhar, it is one of the best case, I think so.
Thank you.
Badly infected. Very good management.
Thank you very much.
Thank
Dr.
you, sir.
Saoji. Dr. Saoji, you want to give some comment?
No.
Okay, so thank you.
Another important point only is the level of osteotomy which he has chosen. I think again it has given a very good, interesting result. And that's a good point which I made out for the LRS. I think it is near the diaphyseal, even it is allowed. But I think it should have been slightly proximal, as Dr. Sanjay Dhar sir has said.
Yeah.
Sir,
but he wanted 3 proximally. So.
Yeah, I wanted the 3 pins, and they need to be spaced in first, third, and fifth seat. Then only we get adequate hold on the bone fragment. That is there. If we compromise on that position, then there are very high chances that our region rate may angulate, and it will deviate from its normal projected trajectory.
Okay.
Thank you very much.
Small question.
Yes, sir. Yes.
Yeah.
Any role of gentamicin cement bead or some cement beads, antibody cement beads?
Yes, sir. Yes. That can be put, sir. The stimulant we can put, sir. I usually prefer stimulant rather than putting the PMMA loaded antibiotic beads, because they absorb themselves. There is no need to take them out. So, and the smaller diameter helps to elute more amount of antibiotic to the infected region. But in this case, because as I've told, there are some financial constraints, so we were not able to put. But I would have put in otherwise other patients.
Okay, thank you.
Yes, sir. Thank you.
Thank you, Dr. Ajit. Thank you for a wonderful case. Thank you very much for finishing it in time. So we move on to the next case. I think Dr. Abhay is presenting. Who is the next, Dr. Abhay?
Abhay, yeah.
Sorry. Dr. Abhay Chhallani. Dr. Abhay Chhallani is lecturer at MGM Medical College, Kamote. He is a well-trained trauma surgeon who does a lot of acetabular and pelvic injuries. So today he is also presenting one pelvic injury only. Dr. Abhay, you can take over.
Yes, sir. I'm sharing my screen. Thank you, everyone. I will be discussing about a pelvic case today. Now, we had this young boy, a 14-year-old, almost 104 kgs of weight, with some psychiatric disorder. He was taking the treatment for bipolar disorders. He was going through waxing and waning of his disorder, depression as well as anxiety. And during this course of treatment, he jumped from 4th floor and sustained the injury to his hip. His ankle was fracture dislocated. 14-year-old boy and heavy weight, 104 kgs. And this is what his CT scan is, 3D CT scan, which shows, sir, shall I proceed, sir?
Yeah, you can carry on. You can carry on right now.
Yeah, so he had this left-sided sacroiliac disruption. He had a transverse fracture going from anterior to posterior. Anterior column was also fractured and posterior column was also fractured. Plus, he has minimal pubic diastasis with inferior pubic ramus fracture of the same side, that is left side. Plus, he had sacral fracture also. Fortunately, he was stable on presentation. There was no neurological deficit. But then we had to keep him in ICU for some time till we got him stabilized hemodynamically. Now, this is a vertical shear type of injury due to fall from the height. Same side ankle fracture dislocation was there, and he sustained this major injury.
Dr. Abhay, just I wanted to stop you for some time. So since good that you have started from a CT scan itself,
Yes,
because I feel that X-rays is very difficult in such situations, and many of us can miss the injuries. So is there any trick or any way that in an X-ray you should, how do you get to suspect these injuries? Because many times we can miss these injuries. So is there any way you can suggest that in an X-ray, what should you look for in such case injuries?
Usually on presentation, sir, we get pelvis with, it starts with clinical examination. If the patient is conscious and well oriented, we do the pelvic compression and distraction test only once by a senior faculty member.
Yeah.
So if the patient has pain and there is high degree of suspicion, then we first we get a PPH X-ray done, wherein there is a distraction in the sacroiliac joint, and we compare it to the opposite side, that is normal side. We can make out the lines if the quality of X-ray is good. But then since we had a very high degree of suspicion in this case, we straight away got the CT scan done.
What I mean to say that it is very important that first person who does the examination, PCT, PDT, or has any hematoma around that area, so he sort of makes it very nicely. Otherwise, you should not keep on repeating this examination from junior most to then senior registrar, and everybody should not put his hand on this. Now with the presence of WhatsApp and all that, I think the first person should record the examination and probably share it with others. Otherwise, you dislodge the hematoma, cause more bleeding. I think that is an important point. Thank you. You can go ahead.
Yes, sir. Plus, we do a per rectal examination by a general surgeon and a catheter immediately after injury to make sure that there is no perurethral bleeding or per rectal bleeding, which usually rules out a visceral injury. Now, this patient, I'm discussing the sacroiliac injury. This patient had associated anterior ring injury with minor pubic diastasis and inferior pubic ramus fracture plus acetabulum fracture. Fortunately, there was no visceral or vascular injuries. Patient had, as I told you, left-sided, same-sided ankle fracture dislocation. So patient was stabilized for almost 48 to 72 hours. He was in ICU. Once the patient was stable, then we were planning for the surgery. Now, this was almost 104 kgs, 14-year-old boy, quite hefty. So we had to plan for a minimally invasive surgery. For his sacroiliac joint.
For my sake, this is a vertical shear injury. For my clarification.
Yes, sir. This is a vertical shear injury. Left-sided vertical shear injury.
Using a pelvic winder or something is not going to help in this.
Yeah, really, yes. But still, we as a protocol, we keep it there, sir.
Okay.
So now, as of now, for his left-sided vertical shear, for sacroiliac, anterior acetabulum, and inferior pubic ramus, I'm discussing about the sacroiliac injury. There are two options as of now. Either we put a percutaneous cannulated cancellous screw or we fix it with a plate. The plate fixation is done through the lateral window of ilioinguinal approach. We fix the sacroiliac joint after anatomical reduction with the help of two DCPs, dynamic compression plates, either 3.5 or 4.5 mm in size, and stabilize the pelvis. So this is another case, another patient wherein this was 18 days old fracture, young adult, different patient, young adult, right-sided open loop pelvis with anterior acetabular fracture. In this case, it was practically difficult during under anesthesia in the OT to compress the injury completely. In that case, we had to open the sacroiliac joint as well as anteriorly also, and we had to fix the sacroiliac disruption with the help of two 3.5 DCPs.
So this can be done through a single approach, or you have to do
different approach. Financial approach for anterior injury for pubic diastasis, and lateral window of ilioinguinal approach for the sacroiliac joint, sir.
So can we go through this extended stopa or something through the same anterior approach? No, it's too high for that.
extended stopas would be difficult, sir.
Yeah.
Laterally, sacroiliac joint would be practically difficult, sir.
Additionally, we can do that is a ASIS osteotomy technique is there. You can osteotomize the ASIS and you can get a good access for all of this inner iliac bone till the SI joint.
Yes, sir.
Sacroiliac can be treated by closed CC screw.
Yes, sir. I have done CC screw for this patient only. This is the other case. In our case, as I was thinking, there are a few issues, like the patient was on psychiatric treatment. He was quite heavyweight, 104 kgs, and we had to finish the surgery at the earliest. So we had planned for an iliosacral screw in this patient. Now, iliosacral screw is a percutaneous procedure done usually under C-arm. There are some Western countries where they do it under, and few centers in India where they do it under navigation. The aim of the iliosacral screw is to do an anatomical reduction and have stable fixation, and anterior instability has to be managed by other approach. Now I'll discuss how we proceeded with the planning of this iliosacral screw fixation in this individual. We have to study the individual anatomy. We have to rule out the pelvic dysmorphism in all the cases. This is another patient where there was, we usually see for the highest point of iliac crest, which usually lies at the L4-5 level, L4-5 disc or lower border of L4 vertebra. We have to make sure that there is no rudimentary disc at L5-S1 level, like we see in this case. Plus, the S1 foramen has to be round. In this case, in this particular CT, it is oval. So this is a sort of pelvic dysmorphism. In case of pelvic dysmorphism, it is always better to avoid the S1 vertebra, and it's preferable to take S2 vertebra, the iliosacral screws, which goes from lateral, from ilium to in the sacrum. It's preferable to put the screw in S2 vertebra to avoid iatrogenic injury to the neural foramen or the nerves. The plan of the screw had to be made preoperatively. In case of iliosacral disruption, the screw has to be perpendicular to the sacroiliac joint. The sacroiliac joint is oblique in sagittal plane, so it's better to go from posterior to anterior perpendicular to the sacroiliac joint. In case of sacral fractures, the joint can be completely horizontal, going in from one-sided, injured-sided sacrum to the opposite sides to have a better hold. The screw should be entirely within the bone, and obviously it has to avoid the nerve root channels. The trajectory, as I discussed now, has to be perpendicular in sacroiliac disruptions, has to be horizontal in sacral fractures. And this is how the screw has to be planned. It has to go in an oblique fashion, that is perpendicular to the sacroiliac joint. Coming to my case, this particular boy had a rudimentary disc, which suggests that this is a sort of pelvic dysmorphism. So putting a screw in S1 is usually out of question. So this is how we planned the screw. Yes, sir.
Yeah, go ahead. Please.
Yeah, this is how we planned for the screw going from lateral to medial in S2 vertebra. We have to calculate the angles either on the CT scan or during surgery. We have to make sure that patient is lying completely horizontal on the bed, on the operation table. We make sure that the lumbar vertebrae are in horizontal orientation. We keep the X-ray beam perpendicular to the ground, and in this way we calculate the inlet and outlet angles. Now the X-ray views which are important during insertion of the iliosacral screws are inlet, outlet and dead lateral views. Now what we are supposed to see on the inlet view? We have to make sure that the S1 or S2 for that matter vertebral body is to be identified. We have to make sure that the screw shouldn't pierce. We shouldn't pierce the anterior cortex of the S1 vertebral body. At the same time, we have to think about the neural tunnels which are going posteriorly. Those should also be avoided. Now, outlet view also is one of the most important views. We have to make sure that the S1 vertebral foramen is seen in a rounded fashion in outlet view. Usually it comes at around 45 degrees angle if the patient is lying horizontally on the table. The most important is the lateral view. With the patient in neutral position with a good C-arm quality, usually in these patients, if it is feasible, we make a bowel preparation, we clear the bowels, so there are no bowel gases during the surgery for intraop imaging. The most important line is the iliac cortical density, ICD, wherein the superior border of the ilium coincides with each other. And this is the superior border or sort of Lakshman Rekha for the sacroiliac screw. The screw shouldn't go beyond this line, beyond the iliac cortical density. The sacral promontory has to be marked clearly on the X-ray, on the C-arm basically. The neural tunnel between the S1 or S2 or S2 or S3 for that matter in dysmorphic pelvis is to be marked on a dead lateral view. And this area, the area between the iliac cortical density and the neural foramen is the safe zone for the iliosacral screw. We shouldn't cross the ICD in any case. Now at times we get a view like this. That means either the hemipelvis is rotated, wherein there is a huge, it's not a single line, it is usually a rectangular shape. That means that the iliac cortical density it is not seen as a single line. Either the fracture is not completely reduced, either of the hemipelvises is rotated, or else the view is not a dead lateral view. Another important landmark is greater sciatic notch. In a dead lateral view, the greater sciatic notches should not superimpose. They should be seen as a different shadows on a dead lateral view of sacrum. Now to reduce our stress during the surgery, it's better that once we get a completely dead lateral view with a normal thin iliac cortical density and neural foramen seen, I usually mark the C-arm levels. So it is very much easy for the X-ray technician or C-arm technician to keep the C-arm at that level. Plus we can mark the angles of the C-arm at 45 degrees, 35 degrees, whatever the angle comes according to the individual anatomy, to make sure that we get a proper and correct view within short time, because every time we have to, as I'll be coming to the technique, the intraop images and all, we have to take a dead lateral view, we have to insert the guide wire, we have to take an AP view, outlet and inlet view. We have to make sure in each view that the neither the cortex of the S1 vertebra nor the neural tunnel or the foramen is breached. So we mark the C-arm level, and this is a standard protocol. To lift the patient's sacrum little above the table level so that we can get a clear image, we usually keep folded sheets so that we get a good lateral sacral view.
Abhay, you need to hurry up a little bit.
Okay, sir, coming to the case, the same old 14-year-old boy, we preferred for a S2 vertebral fixation. We put us two guide wires. First, we reduce the fracture with the help of vertical shear, plus we put some pins in the same-sided ilium and opposite-sided ilium to reduce the fracture, plus vertical traction and internal rotation of the left-sided hemipelvis. After seeing in the lateral view, we go for PBH AP. Now in this view, it seems that the upper wire is going through the foramen, but then in outlet view, we make sure that it is not through the foramen. Plus we get an inlet view and make sure that it is completely within the bone. We proceeded with the posterior wire, measured the length, and we went ahead with the fixation of the screw. We have to make sure that the CC screw passes beyond the half of the opposite half of the S1 vertebral body, and this is how we achieved the compression and fix the iliosacral screw, which is completely within the bone tunnel. Then this is the lateral view. This is the final X-ray. We preferred not putting any plate or fixation for the inferior pubic ramus fracture because of two things. The patient was not very much stable and he was quite hefty. So we preferred this minimally invasive technique. Any questions, sir?
No, you wind up, then I'll ask. I just wanted to ask, when do you think of also adding additional anterior fixation? So in this case, there was an anterior this fracture of the diastasis of the
acceptable.
So since this was an young boy and transverse fracture, we decided to not fix it and let it heal naturally. In cases of anterior pelvic instability, we do an intra-op stress views, and we found that the almost the diastasis is more than 2.5 centimeters. We prefer to fix it with the pubic symphysis plating, sir. And if it is only it is a vertical shear like in this, and still it is anteriorly unstable, then either we fix it with pedicular screw, transcutaneous pedicular screws and percutaneous rod, or external fixator, sir. We take hold in the anterior inferior iliac spine and opposite sided ilium. We keep the fixator for around 6 weeks to 8 weeks, and then we can mobilize the patient after that.
Okay. Go ahead.
Yeah, so to most importantly, the iliosacral screw should be caudal to the iliac cortical density and cephalad to the first sacral disc space to avoid the nerve injury. This is a freehand technique. The navigation is yet to become common in our country. The passage of wire is bounded by the radiographic markers of first sacral body, that is S1 body, S1 foramen inferiorly, L5 S1 intervertebral disc superiorly in outlet view, neural canal posteriorly, and anterior cortex of S1 segment anteriorly, or S2 for that matter in dysmorphic pelvis. The orientation of wire has to be perpendicular in sacroiliac disruptions and has to be horizontal in case of sacral fractures and fracture dislocations. Iliosacral screw is a safe method, relatively safe method, minimally invasive. There is not much blood loss. The chances of infection are reduced. There is as good as no tissue damage, and theoretically it has proved that it provides the same stability as two plates put at an obtuse angle. But then it is not without complications. There are chances of implant failure. There are chances of misplaced screws, chances of nerve injury, and there are chances of suboptimal reductions in delayed injuries.
Thank you, Abhay. Any quick questions, because we are getting short of time? One question.
Abhay, do you do all these surgeries as an emergency or as an elective procedure?
So usually an elective, once the patient is stabilized for 40 to 72 hours to 5 days, then we do it, sir. Unless there is a hematoma which is bleeding continuously inside, then we have to stabilize the pelvis. But then usually it is a damage control orthopedics. We fix it with a single screw, that is iliosacral screw and fixator. Anterior instability, if it was there, we don't open it.
Okay.
Is obesity and contraindication for putting the screw? Because very difficult.
Yeah, yes, sir, it is a bit difficult, but then if the bowels are prepared and we get a good view, then nothing like it.
Yeah.
We need to have a quite a good view plus good C-arm, sir. That is one of the most important prerequisites, because we need to identify the anatomy correctly.
Yeah, with such a soft tissue overlaps with difficult exposure, sometimes we're not able to get such good pictures otherwise. Yeah.
Yes, yeah, this is a good C-arm. This was a good C-arm, sir. Yes, sir.
In our department, we are developing a jig for a posterior fixation.
Oh. Okay, sir.
Okay. Sanjay sir, we can go ahead with for the third case. I think Abhay, it's a wonderful case, very well illustrated with all good diagrams and all stepwise how to put it. Wonderful.
Thank you, sir.
I think we'll go ahead with the third case. I think it is Dr. Gaurav Kanade.
Yeah, sorry, I got disconnected. Yeah, Dr. Gaurav. Dr. Gaurav, am I audible? Yeah.
Yeah.
Yeah, Dr. Gaurav is a associate professor in DY Patil Medical College, a very avid orthoplasty surgeon, and he's going to present his management of a valgus knee. I think is an interesting case. Dr. Gaurav Kanade.
Yeah, good evening all. I will be presenting about the valgus knee management. So I have this lady, 8-year female. She is complaining of bilateral knee pain. She denies any claudication pain or back pain. On examination, we can clearly see the wine soup deformity. Right knee is in valgus. Am I audible?
Yeah, you are audible. You can.
Yeah, carry on.
It's not going.
Not able to. Okay.
So this is a clinical fix. We can see the walking gait, wine soup deformity. So these are her clinical X-rays, the scanogram, the right knee and the AP and lateral. We can clearly see the valgus deformity of around 30 to 40 degree, which increasing on the standing. So what are the valgus knees? These are more difficult knees to balance, less common, less than 10%. So why are they different? As we are really inexperienced about it. So what makes them difficult is the alter anatomy, resulting in the greater difficulty in stabilize the knee and also the patellofemoral joint. It is also sometimes associated with the flexion and extend rotation deformity of the knee. So what are the pertinent issues? So there are etiologies, rheumatoid, primary, post-acute or post-trauma. Passive correction of the deformity is required. Medial collateral laxity is present in some of the cases. Lax or stiff knee. It is always most of the time associated with the hypoplasia of the lateral femoral condyle and wear of the lateral tibial condyle. It may be associated with the foot deformity also, the foot valgus. So this is the same case which I have examined under anesthesia. We can see the complete correction of the deformity under anesthesia. Also, there is flexion deformity which is getting corrected under anesthesia. So these are the stress X-rays.
Or before you proceed, do we take any special X-rays of any, or we follow the routine?
So we should take knee epilateral X-rays, patella skyline view. We get the idea of the patellofemoral alignment on the patella skyline view. Also, we do the stress X-rays.
But important to have a scanogram in these cases, both lower limb standing scanograms, to actually assess the valgus deformity angle.
Yeah. So we go for the stress X-rays, so we can get the idea whether is it getting corrected or not. So what should be our goal? The goal should be to restore the mechanical axis. The hip, knee, and ankle should be in one line with the balanced soft tissues. So how do we achieve our goal? So by releasing the concave lateral side and by rarely riffing the medial side. So now the philosophies have changed. First, they used to do the ligament release laterally to achieve the satisfactory alignment on the of the knee, and then they were going for the bone cuts. But now they have they go for the bone cuts and later they release, because it is shown that if take the bone cut, we get a good exposure of the joint. So these are the lateral soft tissues of the structures. So basically, iliotibial tract, the posterolateral capsule, lateral collateral ligament, lateral gastrocnemius, and biceps femoris come into the play. As in valgus knee, the lateral side is contracted and the medial side is lax. Also, there is whatever the osteophytes which are present on the lateral side, we have to remove. But they don't cause any bowstring effect like they cause on the medial collateral ligament, as the distal end of the lateral collateral ligament is attached on the fibular head, which pushes it away from the tibia. So lateral release in the valgus knee, there are different authors have described the different sequence of lateral release. Care should be taken that we should not over release it. Aim should be to use implant with the minimum constraint. We can go for CRPS or constraint knee. Rarely hinge knee is required. So surgical approaches, medial parapetal, lateral parapetal, or subvastus approach. In case of fixed valgus deformity, the lateral parapatellar is preferred because it is direct and extensile approach to the release of the lateral structures. The skin undermining is less in case of lateral parapatellar. Intern rotation of the tibia can be done so that we can release the posterolateral capsule. Better trisection and sequential release of the can be done to achieve the femoral flexion and extension gap. We can preserve the vascularity of the medial side. Also, we get a better coverage of the soft tissue post closure of the and closure of the prosthesis, and also good for the patella tracking. That is centralizes the quadriceps and the patella centrally. Good alignment we can achieve by the lateral parapatellar approach, and rehab. Rehab is unimpaired as we don't touch the medial side. Sometimes we rarely require to decompress the peroneal nerve, which can be done from the lateral parapatellar approach. So for in this case, I didn't do for the lateral parapatellar. I have gone for the medial parapatellar approach with no medial release. The osteophytes from the lateral side. The meniscectomy followed by cruciate excision. We go for the medial entry point for the tibia. As we can see on the scanogram, if we take the routine middle in the center, the femoral guide, intramedullary guide for the femur, then it may not go in the center of the femur. So we have to go for the medial entry point. So in this case, we can see the worn out lateral femur condyle, and we can see the content defect in the tibia. So,
Gaurav, in such cases, should we prefer a normal bone like femur first or tibia first, or there is any guideline for that?
No, if we are able to dislocate the tibia, then we can go for the tibial cut. As there is defect on the lateral side, we cut less on the lateral side. We keep 2 on the lateral side, but it is really lax knee. So I have cut the minimum from the medial side. Also, I have cut around 6 or 7 from the medial side. So as you can see, there is almost no cut from the lateral side. And for the femur also, There is absolutely no bone cut from the lateral side. So on both the side, at knee was very lax. So both side I have come little less. From the distal femur, I have cut around 6 or 7, and tibia also I have cut around 6 or 7. So our goal should be to equalize the flexion and extension gap. We put in the extensor block and we check for the stability. So how do we achieve the flexion and extension gap? We have to keep in mind that IT band, iliotibial band release will affect the extension gap more, and lateral, collateral or popliteus release will affect the flexion gap more. So this is very important point in case of the rotation of the femur. We should avoid using the posterior contact referencing system for the valgus knee, and it will automatically cause your femur to go into the internal rotation. So as the lateral femoral condyle hypoplastic, you should always use epicondylar axis as our apicut. So how do we release the IT band? So initially,
you should plan your femoral entry on the pre-op X-ray.
Yeah.
Whether to go more medial.
Yeah, we should go more medial, sir. In case of valgus.
Okay.
So IT band release. So IT band initially they used to do it proximally. They used to separate the vastus lateralis from the IT band, and they at least from 5 to 10 centimeters above the joint line, they used to release the from posterior corner of the femur to the posterolateral corner of the femur. But nowadays they have described the simpler method wherein they just release it from the girdis tubercle till the posterolateral corner. If further release is required, then we can go for the posterolateral capsule release, popliteus release, epicondylar osteotomy can be done, and parapatellar release can be done. Whenever we do the epicondylar, the posterolateral carpures or arcuate ligament can be cut. We have to keep the knee in extension. We have to apply the laminar spreader, and with the sharp 50 number weld, we transversely cut the arcuate ligament and the posterolateral capsule. And the epicondylar osteotomy, we didn't fix it back to the bone. We allow it to lie freely over the attached soft tissue. So in this case, after the femoral and femoral preparation and after my flexion and extension gaps were balanced, so I had to do the multiple drill hole over the femur and the content part. To get the hold of the cement, I have put in the 2 screws. And didn't do any bone grafting, as it is what a content.
So, how much of defect would you do? Either an augment or maybe a graft, and only screws.
2 to 3 mm of the defect can be expected.
Okay.
More than that, we'll have to either put the graft or we can go for the wedge. So these are the post-op X-rays. So we can see the good alignment in both the AP and lateral. So this is 1 month post-op. So other procedure can be done. I am not so familiar with it. So lateral gastroc recession can be done if in case of we are not going to get any better release. Bicep Z plasty, fibuloctomy, medial reefing. We can augment the medial side with the semi-T graft or the semi-membranous graft. Constraint implant can be used in case of mediolateral laxity. And in case of flexion extension laxity, we have to use the hinge graft, hinge knee. So more than 90% good results are described by the various authors. Late instability, perennial palsy, patellofemoral problems are higher incidence than in the varus knee. You should always avoid the over release in case of the valgus knee. So these are few more examples of the valgus knee. We can see the collateral instability. So this is the CR knee, rheumatoid. So we have to always be careful in case of rheumatoid patient that they are very osteoporotic. We should always avoid notching, avoid doing any osteotomy in the bone. Complete synovitis has to be done. And most of the authors prefer doing patella as there is more wear in the patella.
Normally, in a varus knee, we accept some amount of lateral lateral opening, like up to 2 millimeters or 3 millimeters.
Yeah.
So, can we accept the same thing on the medial side also in valgus knee? Like if there is some medial opening, or you should consider that augmenting that.
Up to 2 to 3 mm of opening aspect, we can accept, sir, on both sides. In case of varus, lateral opening of around 2 and medial opening of around 1 to 2 mm can be accepted. And in case of valgus knee, the same, the medial side 2 to 3 mm opening can be accepted. So this is the case wherein I have used the constant poly, as it was a RA patient, so I was not able to get the good middolateral stability. So I had to use the constant poly. So constant poly, there are some few cases wherein you have to use. In case of post-traumatic knee, we have to keep standby. Severe RA patients, polio patient, we'll have to always keep the constant backup.
Dr. Gaurav.
Yeah.
Yeah, if there is some sort of residual recurvatum also associated with the valgus deformity, right? So how do you address that recurvatum aspect as well during the TKR?
In case of recurvatum, we should always cut less from the distal femoral. Okay, distal femur and the tibial side also. Yeah. As in this case also, under anesthesia, it was going under the recurvatum around 5 degree, minus 5 degree. So I keep my cuts less. You should always keep your cut less from the distal femoral condyle and from the proximal tibia. The distal femoral condyle is normally 9, so we keep it at -2 around 7 or 6. Same for the tibia also. And in case of flexion deformity, we don't cut more. We always in flexion deformity we remove the posterior osteophytes, release from the posterior aspect. If there is residual even if there is some flexion, then we go for the more cut, +2 or something from the tibia.
Any more questions? You can.
Gaurav, one more question.
Yes,
Dr. Kale.
Yes,
Gaurav, like as you said, medial you prefer, but as when like if there's a valgus knee, normally even the lateral parapatellar approach can be preferred.
It was correctable under anesthesia, so I chose for the medial parapatellar. If it's for fixed deformity not correctable, then we'll have to better to go for the lateral parapatellar. As I already told the advantage of lateral parapatellar. We can, but there are some disadvantages of lateral parapatellar that we won't be able to reflect the. There is very difficult to reflect the patella, and also we may sometimes have to do tibial tubercle osteotomy or quadriceps nips at the quadriceps to get the good exposure.
Thank you, Dr. Gaurav. Thank you for a nice presentation. I think we move on to the next speaker. Next speaker is Dr. Rohan or Dr. Nilesh? Rohan.
Yeah, Rohan.
Yes, sir.
Yeah,
am I audible?
Rohan Gala is again from DY Patil. He is a lecturer and who is a spine surgeon. He's a fellowship trained spine surgeon and he's going to present on spinal metastasis.
I'll be just rushing through 2 cases which would be possibly discussing these 3 points. One is the algorithmic approach toward the spinal metastasis patient. Second is the prognostic score validity while dealing with these patients. And the third is role of neoadjuvant therapy in surgical management. So consider this 57-year-old female who had come to us, known case of renal cell carcinoma, with a D11 pathological fracture and inability to stand for 7 days. On examination, we had the same findings with gross motor power around 4/5, no deficit in bladder or bowel, or sensations were equal. Now, this was with what she had come to us. We got her MRI done. The MRI suggests of a pathological burst fracture at the dorsolumbar junction. It also shows a pathological fracture at D1. And the fracture at the dorsolumbar junction is also compressing the cord. Keeping this in mind, at this stage, my question to the panelists, do you all consider of getting an MRI done? I mean, a PET scan done in these patients at this point in time, or should we still wait? She's presented to us with an acute pathological fracture.
Considering this is a looks like a metastatic disease, so a PET scan would be useful in such cases. Whether and not only for managing this, but also to know the longevity of this and their survival, how to fit them into the criteria for managing them.
Okay, so my question to say Dr. Manoj, let's just say that this patient was not a case of renal cell carcinoma. She had just come with this picture, the current picture.
Yeah.
Would you be forced to do a PET scan, or would you do few more investigations before you jump onto a PET scan?
Yeah, certainly it's like if I would suspecting the lesions at 2 levels with this spinogram, we need to consider the other possibilities as well. Like,
yes.
The multifocal infections are one of the other possibilities, the tuberculosis, infective pathology. Then if the age is more than around 60, then we can certainly think about the myelomas or even the metastatic diseases. So we need to follow that particular algorithm so as to identify which category she is fitting into, and then accordingly we can plan our investigations. Right from the basic screening, the routine blood test investigation, the routine ultrasounds, abdomen, the chest CT, and if they are coming towards some metastatic disease, then they may not be the first PET as a first investigation, but after those investigation, then we will certainly think of a PET scan if could have this as a metastatic disease.
Yeah. So the point actually I wanted to bring out here was that in the absence of an infective pathology, like everything that we have tested for, and if at all we are even biopsying it, in the absence of an infective pathology, do we have other investigations like the HRCT chest abdo or the USG abdo? These are investigations which, if you do, most of the times you can get away without doing a PET in those areas where there is unavailability of this modality.
Yeah.
So moving forward, since we know this was a case of RCC.
Another question from my side. If this would have been an acute presentation for this thoracolumbar region, she has landing up into these problems with the bladder boil, all those kind of involvements with another meds which can support the proximally. Does your approach changes?
Now there are two ways to look at this. First, the clinical examination is of pivotal importance here. Including in this case, I can see another deposit at the D1 vertebra, but she's absolutely asymptomatic for the same. She has intact neurology in the upper limb with some neurological deterioration in the lower limb. So in such a scenario, I would have first done a biopsy because I know that she's not, deteriorating rapidly. Like the deterioration has to be plateauing over time rather than, progressively rapid. So in that case, I would always first do a biopsy and then see, along with the additional investigation that we always right now had a discussion on. So moving ahead, this was the CT scan, which again showed a pathological fracture. And there is a tumor encroachment, which has eaten up the lamina also on the left in the axial cut. So this is a very aggressive tumor. So now that we know that this is a metastatic thing, how much importance do you give to scoring systems like Tokuhashi, Tomita? Do you always consider them when you get a PET scan? Let's just say this female had a deposit elsewhere in the ribs, in the hand, maybe in the acetabulum, multifocal deposits, some few seeding in the brain. Do you give some relevance before considering surgerying these patients to some classification system? Anybody? Like the Tomita, the Tokuhashi, or I don't know. Are there any systems that
they're all very useful scores. I think they can be always used and extrapolated. But I feel the norm score is a very useful score in such situations. So I would prefer rather to use them.
Okay, sir.
Diagnostic point of view, it is very important to score this patient so as to give them a further line of management.
Yes. So these were the scoring systems that at least stood the test of time. The one to your left is the modified Tokuhashi scoring system, and the one to your right is the TOMITA scoring system. Along with that, as we evolved in the subspecialty of spine oncology, we had two new systems. One is the spine instability neoplastic score, which actually tells you whether the patient has an element of instability which needs to be addressed or not. And the second is correctly said by Professor Dhar about the norms criteria, which takes into consideration the neurology, the oncological part, the mechanical stability, as well as whether the patient is systemically fit to undergo any kind of surgery or not. So coming back to our patient, so this is what happened on the PET scan. He had multiple lesions right in the radial head, the sacrum, in the brain, some ribs, and the pathological fracture as mentioned with the primary in the kidney. According to our standard scoring system, the revised Tokuhashi score was around 7. So the life expectancy was less than 6 months. The TOMITA was high, so the expectancy again reduces to 1 year. And the SIN score suggested that the fracture is highly unstable. As per the norms criteria, it was a grade 2 epidural compression, an unstable lesion where systemically the patient could have tolerated surgery. So now, obviously this patient now requires surgery. So how can you plan a surgery where it is beneficial to the patient or do anything as well as increasing the longevity and hoping for a better functional outcome? So this is what our preoperative planning consisted of. We thought of going in percutaneously and only addressing the thoracolumbar met. We were considering a laminectomy, a debulking from one side from where the tumor was encroaching onto the cord, and that material had to be sent for biopsy. Because this is a met from the renal cell carcinoma, one of the most important thing that we have to do is always embolize these patients, because kidney really bleed on. You have a tough time controlling. So ahead, we went for a percutaneous stabilization. We transferred debulking from one, and these were the intraop pictures. So the post-operative protocol was very normal. The patient was mobilized on day 1 because we had done minimal dissection. Pathology was suggestive of renal cell mets. He was referred to an oncologist, immobilized in a SOMI and for the T1 lesion so that it doesn't collapse in the future. Now the oncologist had put her on immunotherapy. So this was one advancement that is now come where profound mets in the renal cell carcinoma patients are treated with immunotherapy, which is mostly axinitinib and the other nivolumab and this. So this patient who had a prognostic survival rate of around 6 months or maybe less than a year, this is for 15 months, but she was just walking in a town in Jaipur where she was consistently taking immunotherapy. So in a way, this immunotherapy along with a very well tailored surgery can actually improve the longevity and the functional outcome of these patients. Unfortunately, she succumbed a few months back. But this is how somewhere where the prognostic systems told us that the longevity, the survival is actually doing more than what is being predicted by these systems. At the critical ones. This is another that So again, we have a 50-year female who comes with spastic compressive myelopathy with sensory level of C6, elsewhere proven to be a case of thyroid carcinoma. This is the picture with what comes. We are getting a routine investigations done. This is her MR. So my question to Dr. Dhar, with such an extensive met from the thyroid, compressing the cord almost eaten up an entire vertebra, what would be your approach in this patient? would you just jump over to surgery because she has deficit and she's like 3/5, or would you just wait? Would you stabilize her posteriorly? How would you see this patient? She's a known case of
We
follicular.
again, as I said, we again apply norms criteria. I generally prefer to use them and see them on oncological parameters, on the extent of disease, their systemic. Since thyroid has a good prognosis, these people survive very long duration. And once you apply these criteria, your anesthetist also is convinced if you discuss with them. Otherwise, they think that we are doing just surgeries for the heck of doing it. So, as you showed in renal carcinoma, she did well for 15. So, thyroid also is a highly good prognostic tumor.
Yes.
So, I would prefer to decompress and give them a good quality of life.
So, sir, in this case, would you have gone and attacked the tumor anteriorly, or would you have given a provisional stabilization posteriorly and then let the neoadjuvant take over?
No. Again, provisional this posterior stabilization, and then think of giving a neoadjuvant suppressive therapy.
Okay, so these are again those MRI pictures. This is the CT where you can see the asymmetric collapse where one vertebra is entirely eaten up. So this is what we did in stage 1. We just stabilized it posteriorly, and after which the patient improved. Her myelopathic symptoms did improve to an extent. So after that, she underwent a total thyroidectomy. Now, one very important point I wanted to highlight was the importance of radioactive iodine in these kind of patients. These patients really do well with radioactive iodine, at least the ones who are sensitive. But the important point is that you cannot start radioactive iodine within 2 months after a thyroidectomy. So if you are undergoing thyroidectomy, you will at least have to wait for another 2 months before you start radioactive iodine. And therefore, these patients need to be addressed before, either via posterior protective approach, so that at least they have some splintage where they are not deteriorating more, because this window will actually cause worsening of deficit if left untreated. So these are the 2 papers which actually show how tremendously various modalities, including radioactive iodine, is doing wonders to patients who are having thyroid carcinoma at a very young age. So this is her 10-month follow-up again, where she is now taking a radioactive iodine, and you can see a slight scaffold forming on the anterior part. There was no bone anteriorly, but after the radioactive iodine, you actually have a scaffolding rim at the anterior part of the vertebra, which was otherwise eaten up, which shows that the tumor was shrinking as well as responding to that iodine therapy. But now we have implant failure. And this was 10 months after the index surgery. So, Dr. Dhar, now would you go ahead and do an anterior reconstruction because the tumor has overall shrunk, or would you just wait and watch? No symptoms though.
I would wait and watch, since, as you said, radioactive iodine does wonders to them and they still survive very long duration. I will just keep a good follow-up because anterior surgery, again, would be a very morbid procedure in such cases. If it is not failing and if it has got a good scaffold anteriorly, I would probably wait and watch.
Okay. Any other takers who think otherwise? No. So again, after doing those conventional prognostic surviving scoring system, like gauging the survival in this patient, she was not supposed to live for more than a year. But here she is 10 months after the index surgery, coming with implant failure to us. So this time we went ahead, we went for an anterior reconstruction because we thought that the tumor has shrunk and there is a slight scaffolding rim with which we could address the same, although there was a void inside it, and we reconstructed it anteriorly. And that's her 7 months after her anterior reconstruction. The implant posteriorly were kept. We didn't address anything. She was asymptomatic for the same, and she's still ambulatory after 7 months of anterior recon. Your takes. Are there any takers for this?
Rohan, a question to you. What, like, as you said, mostly the role of anterior surgery is very less. If, example, in this scenario, by doing a posterior decompression, patient did not improve. Like, would one little earlier for the anterior approach or anterior surgery stabilization?
Sir, Yes, sir. So again, there are two ways to look at this. The anterior surgery actually would have increased the morbidity of this patient for two reasons. One, the patient had not undergone an anterior thyroidectomy as yet. So she had to undergo a thyroidectomy, and we'll have to wait for the 2 months before we could have actually started her radioactive iodine. Second, these tumors, if left the way they were, actually thyroid is actually again a very vascular tumor. So you could have this patient actually bleed to death on table, because with such vascularity and its confluence to the canal, I think how would you excise and to what extent would you have excised? And also the encroachment of the tumor extending laterally into the VA, the vertebral artery, I think it would be too risky with all those feeders supplying this tumor, highly vascular, incising it. I don't think we would have been able to control the bleed on table.
Okay. So
Rohan, you can wind up now.
Yeah.
Yes,
The last question is why didn't you just take out the posterior implants once you've seen that they are failing? And what if there are no symptoms, you just leave it. What is the philosophy?
I mean, if there are if the patient is not symptomatic for a failed implant, and if the implants have not loosened out, there is a rod breakage. The implants haven't loosened out, and you know that she's a metastatic patient. She's already compromised. She's on chemo, radioactive iodine. So many. You would want to avoid a surgical stress on her. The only surgical stress that now she should undergo, ideally, is for the anterior reconstruction. Actually.
Okay.
Yeah. So again, these are the new other modalities. I'll just wind up in 2 minutes, like the stereotactic beam radiotherapy, which are really doing well. And because of these modalities, we can actually get away by just separating the tumor only for even if you separate the tumor which is compressing the cord by 3 to 5 mm, you can rely on these modalities who can actually give you a pain-free management if palliative surgery is to be concerned. So my take-home messages with these two cases would be these spinal metastatic patients always require an algorithmic multidisciplinary approach. You have to rope in the medical oncologist, you have to rope in the radiation oncologist before you actually get a plan for addressing every patient. Second is, we cannot rely on prognostic scoring systems, because many of them have, still, if you see all the research papers that have come till now, nobody is giving a predictive accuracy of more than 60%. And this very important paper that had come with all the stalwarts talking about it, they are like, it actually depends on the baseline performance status of the patient as to how is the patient. So for that, you have to know the Karnofsky performance score and the ECOG grade. What I mean by that is, every patient who has a life expectancy has been able to its presentation and how toxic the patient is or how debilitated he is at presentation. And lastly, neoadjuvants also are a game changer. I think the idea of doing radical surgeries and mobilization has significantly come down because of these neoadjuvant therapies. I think we can now easily get away with smaller, less radical surgeries rather than going complete, the full Monty. So that would be it for now. I thank NMOA and MOA for giving me this opportunity.
Thank you, Dr. Rohan. It was an excellent presentation, very informative. So we move on quickly to the last case. I think Dr. Nilesh Vishwakarma, who is an associate professor in MJ Medical College, Kamote, and a very avid arthroscopist. He is going to present his case on, I think, PCL reconstruction. Dr. Nilesh.
Just a minute, sir. I'll just share again.
Yeah.
Sir, somehow I'm not able to share. I don't know why. Shall I restart?
Yeah.
Accessibility. Zoom is clicked in. Okay. I'll do that again, sir. Not share.
I'm not able to do it.
I don't know why it happened again. I just showed you the entire presentation of.
Yeah, I know.
Oh.
Poonam.
No, so what is happening is it's showing on my Mac that there are, once I click on the keynote, it's showing that system preferences. So I need to open system preferences and security. Okay. Security.
I don't know. Poonam, maybe he could just rejoin the meeting again. That could help.
Yeah.
Huh?
Yes, sir, you can try.
Yeah, I'll just quit and I'll try again.
Yeah.
Just a moment.
Quick, yeah. Till the time, if we are having any questions for the previous presentation, those we can take.
I don't think there is anything in the chat, but anybody who is in this group, they can ask.
Yeah. Rohan, is he there? How do you decide the number of levels of fixation you wanted to do in spine surgery? If there are mets in the 2 or 3 vertebrae, and then how do you decide this fixation spanning these vertebrae?
I think Nilesh has opened this.
Yeah.
In this case, sir?
Yeah, we can see it now, Nilesh. Just 1 minute for Dr. Rohan to answer the question. Yeah, we can see your presentation.
Okay. Sir, I didn't get your question. I think I lost you somewhere.
Okay.
How you decide the levels of fixation?
So at the junctional level, it is best we go 2 above or 2 below. Some surgeons do prefer 3 above or 3 below. A lot depends on how much of the tumor has eaten up the vertebra and how much is the degree of collapse. Somewhere
is in the tumors any different philosophy or it is the same?
It is the same. If at all we are staging the surgery, we can go shorter, where we can go and address the anterior part by reconstructing it anteriorly via an anterior approach. Otherwise, if we are doing an all posterior construct, like let's just say if this tumor had not encroached into the spinal cord and it was a contained lesion, I would have even done a vertebroplasty and just allowed a 2 up, 2 down construct. But for someone where the palliative surgery is concerned and when we are not reoperating, then a 3 up, 3 down is also acceptable. Thank you.
Thank you. Dr. Nilesh, you can start your presentation.
All right, sir. Sir, very good evening, everybody, all seniors and my friends. Dhar, sir, a special thank you to you for giving me this opportunity. And I would also like to say sorry right at the outset, because what has happened is my presentation includes a study rather than starting with a case. So I'll just still go ahead with it, sir. Yeah. So this particular talk will include a PCL avulsion fixation using dual posteromedial portals from the posteromedial compartment. Now, in a PCL reconstruction, normally we take a posteromedial portal. Now, what happens is, in order to aid the PCL surgery steps, we additionally take a transseptal portal and a posterolateral portal. But posterolateral compartment is 1.5 times smaller than the posteromedial compartment, and the portal needs to be created from outside in technique before, and it may be really difficult to enter the smaller posterolateral compartment, and there is a huge risk of actually injuring the neurovascular bundle. So that is why the alteration or the modification that can be done is using dual posteromedial portals rather than going for a risky transseptal or a posterolateral portal. So we did this study, a prospective cohort study from January 2014 to 2020, Jan, and we aimed at evaluating the outcomes of PCL fixation with screws using dual posteromedial portals. So we included isolated PCL avulsion fractures with closed physis in order to negate all these compounding factors, and we excluded any patient who had a fragment which is less than 1 centimeter, pre-existing knee arthrosis, multiligamentous knee injuries, any extension of the fracture on the tibial plateau, either medially or laterally, and the avulsion fractures that were beyond 12 weeks. So we carried on with the clinical examination initially, and the x-rays are routine x-rays. Normally stress x-rays are not advised unless we suspect any kind of additional injuries as well, or if it is a fixed posterior sag and all neglected injuries, yes, then stress x-rays will be advisable. MRI is definitely routinely advised, and depending upon the size of the fragment, the order for the CT scan can also be advised in case if you're not sure about the size of the fragment. Now coming to the technique, now this particular video that I have put here, it has got a combination of the suture fixation technique as well as the screw fixation technique. And in such kind of situation, again, this video has got an embedded audio onto it. So I'll just start with the video right now. And the posteromedial portals are basically shown here, and there are two ways.
The posteromedial compartment can be accessed arthroscopically through the ACL-PCL intercruciate window or through the window between the medial femoral condyle and the posterior cruciate ligament.
Sir, if any questions are there throughout in this particular video, just let me know. I'll be very happy to answer them right away itself, sir. So what we are going here, we are going through the scope into the posteromedial compartment in a case of PCL avulsion fractures. And once we are through in the posteromedial compartment,
once the posteromedial compartment is visualized, the two posteromedial portals are created by outside-in technique in the safe zone. The space between the two portals is decided by the modality of fixation to be used. The portals can be closed if suture technique has to be utilized. If screw fixation is anticipated, then the proximal portal can be placed even more proximally so that the trajectory for the screw is optimum. The proximal portal is termed as the working portal. The suture passer gun can be passed through the working portal to take a bite through the entire bulk of the posterior cruciate ligament. This is followed by a fiber wire in a cinch configuration, which can be passed through the tibial tunnel for suture fixation of the PCL tibial avulsion fracture.
this is the most commonly used way to fix the PCL avulsion fractures, and even if the fragment is very, very small.
Repositioning of the cinch is relatively easy with the instrument passing from the proximal working portal.
Now this will show the cannulated screw method.
A drill bit is passed through the proximal portal for posterior cruciate ligament facet compression. Then a guide wire is passed, followed by a drill bit over it for weaning. This is followed by a 4 mm cancellous cannulated screw over washer. Continuous positive pump pressure aids in pushing the posterior capsule away from the screw. The screw fixation is performed when the fragment is non-comminuted.
So we'll go ahead with the results that we had with the kind of study that we had actually carried on. So we had 75% of the male population in our study, and the average mean age was 39.9 years with the range from 29 to 50 years. The most common modality of injury was the dashboard injury, which is the road traffic accident, which was 41.7%. Now, this was actually in confirmation with the multiple studies that are available in literature. The mean Lasham and the IKDC scores at the end of 6 months were 75.4 and 89.3 respectively. So the preoperative IKDC, or the International Knee Documentation Committee score, with a mean of 10.13 increased to 89.3 at the end of 6 months. Now, this was really, it did validate statistically the significant improvement in this particular modality. All the x-rays showed fracture union by 6 weeks, except one case which showed delayed union but consolidated at 16 weeks. There were no complications directly related to the surgical procedure itself, as failure of fixation, neurovascular injury, superficial or deep infection associated with this. Now, coming to the complications, yes, there were significant complications which are there with this particular kind of fractures. We found that grade 1 posterior sag was there in 41.6%. Difficulty in squatting at the end of 6 months was there in 8.3%. There was a temporary extension lag that was present in 16.7%, as well as fixed subtle flexion deficit of 3 to 5 degrees occurred in 8.3%. Now, we looked upon to the literature for all such kind of complications that are there. So we did find that even though our complication of residual posterior instability was 41.6%, but literature showed that the range of 3.4% ranging up to 95% of residual posterior instability is still present. So multiple studies did validate this kind of complication. Coming to the motion deficit, flexion deficits are more common with arthroscopic surgeries. So this was basically shown by Nicandri et al. In 2008, and we also had similar kind of complication in our study as well. Coming to drawbacks of our study, it was not possible to define the normal angle interval for the screw trajectory, even passing through the high posteromedial portal for that particular angulation. Now, this angle, which may injure the common peroneal nerve if passed bicortically, and the screw obliquity can only be validated by cadaveric studies. So we did not actually pass any of these screws per se, which were bicortical in such kind of situation. To our knowledge, there are no papers in the literature with arthroscopic screw fixation for PCL avulsion fractures. There are papers which will show the suture method. There are papers which will show the polysteres, PDS, tightrope RT, but open PCL screw fixations are also there, but arthroscopic screw fixation is not there as a reference. Our study actually had a very short follow-up of 6 months, so we couldn't actually reassess or assess the patellofemoral problems that would have developed, or any kind of subtle advanced arthrosis also that could be a complication thereafter. There was a lack of case and control, although we found that some published papers, even with fewer patients as compared to our study. So the PCL avulsion screw fixation by dual posteromedial portal technique was similar to the open approach when it comes to outcome. Nevertheless, the mild flexion deficits and the discrete posterior sag may be present in a significant number of cases. I think that would be the end of this particular presentation, and I'll be really happy if there are any kind of doubts. I don't think there would be any, because nobody did stop me from any of these amongst these slides. Yes, sir.
I think it's a wonderful presentation. It's a very unique, different technique. It is technically very challenging and very demanding technique, I suppose. Very difficult to get a good screw trajectory through those portals, which we get with a mini open or a single L-shaped small incision.
Yeah, sir, I'll share one slide here right now. So if you will see, we are in the process of actually trying to see the trajectory of this screw. So I'll just enlarge this one. And if you'll see that there are a few angles that are drawn on this particular slide, which are basically alpha and beta angles that we have turned along with the other authors. And we are in the process of trying to see whether all these kind of angles can have a normal range. And I will probably do an cadaveric study in MGM hospital itself to validate such kind of studies. So that is what we are looking at.
Yeah, absolutely fantastic. This would have been a great technical
novel presentation.
Thank you, sir.
So if there are no further questions, Sanjay, Dhar, sir, anything?
No, I think excellent presentation. Personally, I don't do any arthroscopy, so I would not be in a position to question it.
Yeah.
My only question at the most means, do you see any graft breakages, this fragment breakages while doing this?
Yes, sir. So normally the only reason of doing a CT scan in such kind of patients would be to evaluate the size of the fragment, sir. If the fragment size is less than 1 centimeter, absolutely screw fixation is to be obviated. The combination of that particular fragment will definitely take place. In fact, my limit would be 1.5 centimeters. If you look at it, the PCL facet itself is 1.5 centimeters. So if you use any kind of fragment which is less than that, probably will not be you'll not be able to do justice. So suture fixations are really very good in such kind of cases. And honestly, when you do a suture fixation, you have got an opportunity to actually over tighten it, because most of these injuries are actually not avulsion fractures. There is certain kind of elongation that takes place in the PCL substance itself. So when you try to pull it down, it is better that that residual instability probably that persists even after the ACL avulsion fixations may not be there with suture fixation.
Suture anchors.
That is where
just in addition to that, can we just put the suture anchors into the bed and then take out those anchors and just tie? That is an additional simple way to do it sometimes.
Yes, Manoj sir, yeah, that is a possibility. In fact, people have used swivel lock also, so that actually creates a hole and you just tap in and it takes a very good hold onto the bone. So that is definitely a very good.
That I have started doing with the open technique, not the scoping technique. But certainly that is giving a good, easy, not to look for the trajectory for the screw. Very easy to do it and good, certainly get a good anchorage as well. So fantastic presentation and excellent.
Yeah. Is it screw 4 mm cannulated?
Yes, a 4 mm cancellous cannulated screw. And we haven't tried on any kind of mini fragment or small fragment screws onto it if the fragment size is small, sir.
So I think maybe I will ask Dr. Kiran Saoji sir to present a
Yeah.
thanks.
Thank you very much, all the participants, for excellent presentations. It was
Thank you, sir.
really great. So I hand it over back to Dr. Kiran Saoji to wind it up and close the meeting.
Sir, Saoji sir, you are muted.
Navi Mumbai Orthopedic Association. No, there is a problem. I'm hello.
Yeah, now we are able to listen.
We can hear you.
Audible?
Yeah, we can hear you, sir.
On behalf of Maharashtra Orthopedic Association, I am very much thankful to all presenters, especially Dhar sir, and Navi Mumbai Orthopedic Association. First of all, Ajit Chalak has presented very good Elizaro infected case. Then Abhay Chalani presented a pelvic, who has presented a pelvic two cases and fantastically done. Then Gaurav Kanade, who has shown a valgus knee TKR, and Rohan, who has also shown a spine case, metastatic spine case. Am I audible?
Yeah, we can hear you.
Then coming to the Nilesh's case, fantastic new method of fixation of PCL by arthroscope. So I hope we have added some knowledge to we have added knowledge to us, and I hope you will also cooperate in future also.
Sure,
Thank you very much.
It's always an honor.
Yeah, I must thank Dr. Sanjay Dhar sir for I hadn't to do anything. He has already selected the topics, the presentations. So it's a smooth flow with whatever cases which we could have today. And thank you, Sanjay Dhar sir and the Navi Mumbai Orthopedic Association, as well as all the speakers along with the OrthoTV for their technical and this broadcast support throughout. So hopefully we would have another and the NMOA president as well as secretary for being the guest society for this 24th episode of Young Surgeon Forum. Hopefully we will have further more episode with the association further ahead, especially with Dr. Sanjay Dhar sir with the BOS in the coming year. And I thank you all again for your
incoming president.
Yes, sir, I know. And taking out time on this Dahi Handi and the Sri Krishna celebrations, which are already going, I think, at every home outside. So we will finish it with this thing. And again, I thank you all. Have a
thank you, Gadegone sir, also for
Good night. Good night.
Thank you and good night.
Thank you, sir.
good night.
Bye bye.
Good night, sir. Good night.
Good night. Bye.
Yes, sir.